Before I welcome our guests, I'd like to invite those who have not already done so. Please subscribe to our YouTube channel, Magnimind Academy. We upload recorded sessions of these talks so you can watch them later. And you can also comment on the live stream, any questions that you have or any comments about today's talk. Now I'd like to welcome Jasmine Wilkerson and her talk, Machine Learning in Healthcare, Opportunities and Challenges. At Magnimind, we try to find speakers who can deliver workshops like these that give current information or a different perspective to go along with our data science education programs. These programs range from focusing on the fundamental skills of data science all the way to helping career change into the industry. Our goal at Magnimind is impacting as many careers as we can, and this is just one way that we do so. Wilkerson joins us as the lead senior data scientist at Kensai, a company focused on implementing principles of data science into healthcare. In the past, we've had several talks on healthcare, and I'm sure a lot of viewers are here from those talks as well. She'll be focusing on her own experience in carrying out this vision and the challenges she faced in doing so. Graduating from Southern Illinois University on full scholarship, Wilkerson got her bachelor's in chemistry and went on to Texas A&M for a master's in statistics. She has worked as a research scientist for Southern Illinois and Washington University for a combined almost 15 years and has been a data scientist for over 5 years. We're very excited to have her, and please now give your full attention to Jasmine Wilkerson.
Hi, how are you? So this is actually my first event for this meetup, so I am not very familiar with the group of attendees in terms of your background. Are you mainly data scientist? Are you data engineer? Or it's just a mixture? So I'm going to try my best to present something in a very broad stroke from healthcare, anything that I know, experience that I have in healthcare, and I'm happy to share with the audience. But give me a feedback or ask me a question if you feel like you would like to discuss a certain area a little bit more. So the way I see this go is more of I would like to have more of an open discussion if you guys have questions. So feel free to ask. So quick introduction. I think the organizer has did a pretty good job describing my background. I have been with Kensai for about 3.5 years, so primarily working on a healthcare space. Prior to that, I also with another company, Xerox. Apparently, Xerox has an analytics company, so they don't just sell printing machine, and also focusing on population health. And prior to that, I was focusing on genetics, genotyping, and bioinformatics research. So a pretty wide range of experience, but I'm always sort of on track on pursuing healthcare in the space of healthcare, and this is the area that I'm very passionate about. And hopefully, I can inspire some of you guys to venture into this space, because it's a lot of fun. All right, I'm gonna go ahead and share my screen. So I have a question for the panelists, and are we gonna take questions, or will you guys curate some of the questions and they will send you questions? How does that work?
So usually the questions will be put into the Q&A, and you kind of have the option. Either you can answer them as they come up and I can interrupt you and just dictate them to you, or you can wait until the very end and then just answer them all at once.
Okay. I guess I can take it along the way. Maybe that will, yeah, I'll take it along the way.
All right, sure. The Q&A button, it should be right next to the share screen button. You can see all the questions coming in there. I'm on full screen though. Will I be able to see it? I think so. If you just click it.
Okay. Okay. Well, let's give it a try, yeah, and see what happens.
Yeah. All right.
Okay. All right. So here's the introduction slides. This is me, Jasmine Wilkerson. Work at the lead data scientist for Kensai, and agenda of today is mainly I want to focusing on just the challenges and the opportunity. So you're not going to see a lot of very technical discussion on data scientists or machine learning, but I would touch on some of the high level in the area that you should be focusing on and the opportunity that you might have in that specific area. So the challenges, the way I see challenges are two parts. One is the healthcare itself has its own challenge. And then because of that, then the machine learning, whenever you're solving this problem, you're going to run into a different set of challenge, or whether you're just trying to solve the other problems. So I see this as a two-part, it's a twofold of the challenges. Then we'll have an open discussion for that. Now, from my perspective, I also see challenges is equals to opportunity. What that means is if there's a problem to be solved and there is opportunity for us to solve it. So that's why I see them as equal. As you go along the talk, you will hear maybe sometimes I use them interchangeable when I'm giving an example. In my opinion, I think they are almost equal. If there's no problem in healthcare, then we don't even need to talk about this, right? All right, so I want to start the talk by defining what are the challenges. So these challenges are defined by the HHS, which is the Federal Human and Health Services, Health and Human Services. So every year they will release some plans and strategy about how do they want to tackle some of these healthcare issues. So if you go to the link below, you can actually go to their Federal Healthcare IT, which is their department, strategize what is their plans moving forward to basically improve the healthcare overall. So basically they define the challenges in healthcare into 5 different categories. And of course, these challenges there are many other challenges, but these are just the top 5. And then it can change from time to time, right? Maybe 10 years ago, the rate of mental illness and substance use disorder wasn't a problem, but it started to seem like it is a problem right now. Now, substance abuse, mental illness, poor health outcome, access to technology, access to care, and increased healthcare spending. I think some of these are not surprise to you guys, for those who are familiar in healthcare. I am seeing question. So if I click on it, should I be able to see the question? Okay, hang on, I'm gonna have.
Yes, you can leave the Q&A on the side. Whenever question comes, you may answer, or you can just look at whenever you feel there's a break, so it doesn't interrupt you.
Okay, I'm still trying to figure out how to use this. All right, bear with me, yeah? Okay, let's dive in a little bit more when we talk about what is the increase of healthcare spending look like. So on this diagram, if you are comparing the expenditure per capita, per GDP per capita, with other similar countries, other developed countries that it's comparable, you can see that US is almost twice as much. Like we're so out of bounds. So that means that we actually use a lot more. On average, we spend, like per person spends almost twice as much, right, compared to other developed nations. And then on the other side, if you look at this, and we're not seeing that healthcare spending is slowing down. It is continue to increase in a pretty significant rate over time. And it's also estimated by the HHS by the year 2025, it's estimating we're going to spend more than 5.3 trillion in healthcare spending. One thing, interesting facts that I read is it's the prices you paid. It's different. It's very different from places to places. I recently had this project. It's predicting some form of cost. Surprisingly, location is like the #1 factor. If you just shop around, sometimes you can go to a cheaper place and get a surgery done. But it is a surprise to me how varied those numbers are. Okay. Now the next thing that we can look at is the disparity in healthcare. I got this table from the KSF. It's a very good resources for you folks to kind of figure out what's happening in terms of healthcare. This is from Kaiser Family Foundation. Has a lot of very rich information, that you can look into. So social determinants of health is a very, very, very important factor. And when we're looking at whether it's health income, access to health, technology challenges, these are very important feature and factor that is creating the challenges in healthcare. So, for example, if you are uninsured, you cannot afford insurance, or you don't have a job that can give you insurance, you are unlikely not to want to go to a hospital. You're trying to avoid getting treatment. Sometimes, that will contribute to a worse health outcome. And even if you seek care, you may end up having a huge financial burden because of that. Now, the lack of access, I mean, for at least for myself, working in a tech company or being in a tech industry, it is really hard for me to imagine that people doesn't have access to broadband internet. But it is true, there's still quite a bit of areas that doesn't have that services. And that sort of introduced the barrier for being able to have more of a cost-effective way for treatment, or having the patients having the ability to access to their health information. That's another challenge.
We actually already have 3 questions if you'd like to answer them. The first,
how
do you...
Go ahead.
Oh, no, sorry, what were you saying?
No, I was trying to click on it and see if I can see the questions, but I actually cannot. If you don't mind, please say the questions.
Okay, yeah. How do you provide confidence to the general population that your data will remain anonymous?
How do I provide, say it again?
How do you provide confidence to the general population that your data will remain anonymous?
Okay, so how do I provide, how do I tell people that my model is good while still preserving basically the privacy of the data? Is that the question?
I guess so.
Okay.
Yeah.
I think we can get to that later. I'm gonna have that right down because I do have things like that, data privacy. Yeah. Okay.
Okay, sure. There's 2 more. How do you
Go
gather difficult data sets? Yeah.
Okay. And then one more.
Oh, and then the last one would be, okay, sure. And the last one is, why do you think there's an increasing rate of mental illness today?
Oh, mental illness. I can't answer the third one, only because I felt like I'm not a epidemiologist, nor am I a medical doctor. And we can attribute that to, people can say like there are import drugs from a different country, or provider overprescribes. It's another area that I'm going to touch upon. We actually have a publication on that, the project that I work on. I can touch on that in a bit. But I don't know, it's a social issue. People are stressed, mental illness related to drugs abuse. There's all kinds of reasons, but definitely I felt like the social factor is pretty much in play here. Okay, I will get to the first 2 questions later. Yeah. All right. So the other thing that I want to look at. Okay. So other thing I want to talk about is also looking at, does it mean that with the higher medical costs, higher healthcare costs, we are actually getting a better quality of care? Now, the one on the left is telling you that the mortality rates, is falling steadily in the U.S. But then if you look at from other countries as well, other comparable countries, generally, mortality rates are going down just from advancement in technology, knowledge of science. Now, the next interesting thing to look at is now mortality rate is going down, but is other area like hospital admission rates going up in comparison? And we do see evidence that the U.S. has much higher readmission rate for CHF, congestive heart failure, for asthma. We're doing a little bit better on hypertension and the diabetes, right? And then if you're also looking at the error rate, now the argument is, well, I pay a lot more, but, do I actually get a better service, a higher quality? If you look at the error rate, the United States is actually on the top, right? 19% compared to other comparable countries. On average, it's about 12%.
Okay, there's one more question coming in.
Sure.
What kind of SDOH companies have you worked with, and what kind of service do they provide?
SDOS. What is SDOS?
It says SDOH.
Department, SDOH. I don't know what that is. So if you can provide that.
Social determinants of health.
Oh, social determinant of health.
Yeah.
You mean like how many companies that I have worked with? Okay, I'll get to that question. I do wish that I can see the question. Let's see. Oh, okay, I can see it here. Okay. I'll answer that when we have a discussion, yeah? Now I look at the mental illness here. And we also see that from some of the research and some of the report that I found, it seems like there are, for a certain group, we're definitely seeing an increase in the overdose deaths. And then we're also looking at the suicide rates, and it's definitely on the trend to go up as well. These are indicators of mental illness and substance abuse. Okay. So now we have identified, we have narrowed it down to the challenges that we want to kind of focusing on. So what I did here is, so all this different circle, I was trying to figure out, okay, well, we have all problem. How can we categorize an areas of intervention that can actually solve this problem? So I bucketized them to a couple categories based on what I know. I mean, this is not exhaustive list, just based on what I know. When I talk about patient care, I meant it as at the point of care. Let's say I am a doctor and I have a prediction result from a prediction model, and I am making decision based on that prediction, and I treat the patient based on that. So it's a point of care. From the patient level. When I talk about risk management, think of it like, let's say Jasmine has diabetes, and I don't know how to manage my chronic condition, and I would like to know what are the programs that I can go to. Now, maybe this is a health plan, and this could be my doctor who can identify a member or a pool of patients or members that is high risk and say, hey, we're going to send out flyers to, or make phone calls to Jasmine, because Jasmine is recently diagnosed with diabetes, and we need to manage her risk. Yeah. Now the imagings are things like genetics. Now let's say MRI, X-rays, and things like that will help in diagnosis. And devices is more things like let's say IoT, wearable. It could even mean the implants, right? Somebody wants to have a hip and knee surgeries, and then they want to use a certain type of implants, and they want to know, they want to have a prediction of like which implants is better or which procedure is better for that particular implant. And the population health is more referring to things like we want to know what is the prevalence of a disease in a certain area, where's the disparities happening. Is it a problem of access of care? More of an epi type of questions, less of an individual questions. I think detect waste is an area that is very interesting. And healthcare is really expensive, right? All this cost is going to trickle down to the patient and sometimes the insurance, if the insurance will pay for it. But if you really look at the data, very often you will see there is inefficiency in many, many areas, whether in overprescribing medication, it could be even things like in the supply chain. That is a true problem in healthcare as well, right? Supply chain is a problem. And yeah, let's say process inefficiency is more targeting to a process within, let's say within an organization. It's very targeted to the organization. One example that I can give is, let's say patient flow, right? When I talk about patient flow, is think about patient come into the emergency room. Emergency room is very crowded. And why is the emergency room very crowded? Because there is not enough beds for the hospital to check patients in to those beds. Now, why is those beds occupied? Think about like a hotel, right? You go to a hotel and that's all full, there's no vacancy. And therefore, anyone coming into emergency, even they need to be admitted as an inpatient, they may not be able to get in, right? Now you have to understand, why are they full? Are these people supposed to be there, or they should be discharged earlier, but they did not get discharged? So that's a real problem that we're seeing in a lot of the hospital. Very often people are ready to go home. However, the nurse or the discharge manager just did not have time to get to your case to really evaluate whether you should be discharged today or not. So these are the areas that I have learned from my experience working with some health system and solving some of the efficiency. Another area of efficiency could be things like appointments, for example, and people with no show. So every time you have an appointment and then the patient doesn't come, and that is actually can cause some inefficiency in terms of like arranging the provider's time and things like that. So it is a real prediction problem that we're also solving. So now with these area of intervention, so I started to map it to the problems which I think has the biggest, has a higher impact, right? So you can argue that the population health will have impact on the healthcare spending, but I think its job is, it probably has a higher impact if we put it on in the poor health outcome, right? So you want to be able to find the areas or the cohort of people that really need special attention that will ultimately improve the health outcome. I'm going to stay in this slide for like maybe 10 seconds. I don't know if you guys have any questions. I know this is a lot of information here. Oh, we can come back to that. Okay. So as sometimes it is useful for me to see. I'm trying to get back. Okay. So sometimes it's very, if I'm going to spend my energy, I think sometimes this categories is helping me to say like where in the area that I can provide the best impact, or even from the product perspective. If you work for a healthcare company, sometimes you have to think about like, okay, what area that has the most problems to solve, the variety of the problem, what kind of impact that we can make in a certain area. Okay, so here I want to give you some example of what are the good ML problems to solve, right? So this will be example around the challenges that we have identified earlier, and then the area of intervention that we think could be very helpful to solve this problem. So identify wasteful spending. So when we talk about wasteful spending, this is very much talking about like dollar sign, right? Did you overprescribe? Did you prescribe a procedure that is not required? Why is one provider cost more than the other? It's very surprised. You will see some interesting things from data. I can give you one example. I have seen a prescription for a patient. There are 4 different types of opioids being prescribed for one patient. And the 5th drug being prescribed is to deal with the side effect of having 4 different types of opioids, right? So these are the type of things that is very interesting that you'll find out, and we want to be able to use machine learning to find them. We call it the needle in the haystack. And it is very difficult for our health system to really find those problems. So I think this is the area where machine learning can really help. So wasteful spending occur in healthcare organizations. So what that means is we want to know what is wasteful. You also know where, right? When you know where, that's where you can make a difference. A lot of these wasteful sometimes is not done intentionally. It was just the system. Let's say you have an automated filling system for a particular type of drug. For this surgery, you always use a specific brand or specific doses, right? And over time, you don't even notice that there's other cheaper and equivalent options. So not to say there is one provider who is doing this out of fraud, but very often it's just happened that this wasteful spending occur unintentionally in many areas, whether from a department, from a location. Now, who is contributing to the wasteful? And these are more on providers' behavior or preferences. Very often, provider has, basically they trust. Let's say if I always prescribe ibuprofen to treat certain thing, certain disease, ibuprofen is just, for headache, for example, and I know it always works. So out of habit, I will always prescribe the same thing, right? Regardless of whether there's other better options or cheaper equivalent options. So again, I don't want to say that it is a fraud being committed here, but very often it is a wasteful based on some sort of habit. Now, when is the wasteful occurring? Sometimes in certain seasons, sometimes there's a shift, meaning like, let's say by December, there's always a new contract being negotiated in the supply chain. And then suddenly the price got bumped and nobody's noticed it. There's all kinds of things that are based on some sort of time element to it. Okay, I'm going to move over to the improved efficiency. So I give the example of the patient flow, and I also give an example of no-show at the appointment earlier, and where in current process failed to identify targeted cohort. Okay. So this is an example that I have seen very often, let's say in organizations, when they have a program to say, I want to be able to find a cohort of people that has a very specific condition so that I can do something to prevent that from happening, right? Think about preventative. Like I want to be able to find who is going to end up with a risk of readmission for the next 30 days. A lot of these existing solutions are using rule-based. You'll be surprised how many of them are just based on rules. If they come and see the doctor for this XYZ condition and they are taking this drug, therefore they're high risk, for example. Very, very minimum. And what you'll notice is they actually, let's say they know the prevalence is about 12% for a specific condition, but they will know their processes is lacking because they're only able to capture, let's say 7%, right? So that's where the machine learning can come in and help to just using a lots of data that is much better than a rule-based that cannot update itself. Okay, let's see, improve outcomes. So these are more around improve health in general, and how would the providers give best treatments to patients? So these are providers can use technology, can use diagnosis tool, accompany that with prediction models. These are a couple things, many things they can do, right? Disease management is another area. We are shifting towards a preventative measure, meaning it is better to prevent an event from happening than the patients ended up in ER. Overall, it's going to cost everybody more, whether the health system or the patients or the payer as well. And which patients need preventative care to improve outcome. So this is what I mentioned is having the ability to predict a specific risk population, right? So that you have a group of people that you can intervene. Having risk of having adverse effect in polypharmacy, this is another problem that we're seeing. And very often, if that patient is getting multiple drugs from the different locations, sometimes you don't know how many drugs they are taking. And overprescribed opioids, we work with a health system. Basically, we want to identify which providers have anomaly prescribing behavior. These are the projects that we actually quite successful in one of the health systems that we did.
Okay, we have another question. What are your thoughts on the problem of individualized or personalized healthcare? And is it mentioned in the Federal Health Strategic Plan? What machine learning methods do we currently have to address that?
Individualized healthcare. If I read this question correctly, you meant it as in like the targeted treatment that is based on what we know about you, right? Let's say targeted treatments, let's say personalized would be things like genomics. Let's say if I take a sequence of myself, then I would know what kind of cancer treatment is best suited based on my genetic components. Is that correct? And what do I think about that? I don't have a lot of knowledge on that, but I do strongly believe in sequencing. And we see a lot of success in a lot of cancer treatments, because let's say you take a biopsy of a tumor and you can sequence the tumor based on that. And then you go back to any sort of history that you have for that particular type of tumor, and you actually know which drugs will give you the best response. If you look at more traditional treatment, is they will give you one drug first, and then if you're not responding, they're gonna go to the second one, and then so on and so forth, right? So that is, I think it's pretty common to do. I will be surprised that a cancer patient are not being offered to have the tumor cell sequence. One thing that I'm not sure though is whether the insurance will pay for it. But let's say if I got cancer, that's the first thing I'm going to do, like please sequence my tumor cell. For sure, I'm going to have them do that. The other area of personalized medicine is something that I touch upon, that I have the opportunity to work with, is the drug susceptibility. And if you see, there are a lot of different race will have a different susceptibility to a certain type of drugs. For example, warfarin is one of the very common drugs to treat heart disease. It's a blood thinning drug, right? And then it is more likely for an Asian descendant patient to have internal bleeding if the doses are not being adjusted properly. But I think there's only three SNPs that you can sequence, 3 or 4 SNPs that you can sequence. And I can tell you that whether you are sensitive to this drug or not, right? So I think these are the area that definitely we should push forward, whether as an industry or as an individual, to really demand to have treatments that is very personalized to us. I hope that answers your question.
Thank you.
All right. Okay, let's see. All right, I'm gonna move forward to the machine learning challenges in healthcare. So there are a lot of different type of data. First of all, we have to understand the healthcare data are collected for a billing purposes. They are not designed, like there's no data collection design being considered as in like, how do I collect health information? But rather, these are necessity elements that the health system collected for billing purposes. So there is a nuance difference sometimes, right? Even though you can say that I can find who has a visit to ED visit, But then there may be the coding of it. Let's say what ICD-10 is considered as ED visit. That grouping could be different, right? Because each system may code it differently. Again, they're for billing purposes. They are not looking at what are the risks of the ED visit. I hope that's clear. And the other thing is the data is very fragmented, right? When I say fragmented is there are many types of data that sort of have a little portion of representing a piece of a patient or a piece of individual or a group cohort, right? So claims data is one. For every individual has visited the hospital or inpatient, outpatients, or even pharmacy prescriptions. There's a piece of claims data about you on that particular visit. Then EHR are the data that that's being collected when you go visit your provider. And then the social economics and social determinant data, very often we see very limited information we can get from the claims and from the EHR data, which is very frustrating. So very often we have to go out into the third party to find those sources. One of the challenge with finding resources that outside of the health system environment is the integration of those information back into your solution. I'll touch upon a little bit on that later, but that's one of the challenge, right? Like, do we know if these informations are updated yearly, monthly, and that kind of stuff, right? If it's not captured within this hospital or this health system, then it's really hard to bring it in. Now, the genomics and imaging data, these are quite, let's say, specifically for genomics, not everybody is sort of having, collecting that in a health system. So only more of an advanced hospital or system will have that, right? Imaging data, again, there are a very particular way of collecting it, and they are not always integrated in the EHR, and it's hard to get. When I say hard to get, meaning like, let's say for this encounter, Jasmine go to see a doctor, I need to take an MRI, right? Now the MRI may be administered and the data is being collected by a different system. Let's say the EHR is being collected with the Epic system. Now the imaging, the MRI is collected by Allscripts, for instance. Then these two doesn't talk. It's very frustrating when you're trying to make that connection of this visit event to an imaging event. Then we're still seeing a lot of text data, and this is an area that's very interesting. I do think that there's a lot of opportunity and a lot of interest in it, but nevertheless, it is an area that is a little bit tough to get to. Now the size is, how do I say it? I think people think that machine learning, we're gonna have a lot of big data, but the truth is in healthcare data, we don't have a big data. We're still playing with, like, I wouldn't say small set as just like couple rows. I meant like if you compare to retail data, compare to shopping data, compare to clicks data, we are many magnitude smaller than the data that you can get in a lot of the commercial space. Especially we don't have transaction data, right? Data common schema. There is not a common, how do I say it, mapping across different systems, right? If you're talking about, there's some standards, for example, ICD-10 is pretty standard to record any sort of diagnosis. But then there will be some other type of grouping, for example, lab code. They may use a different kind of grouping. Pharmacy, they may subscribe to this kind of pharmacy class, a drug class called AHFS. So there's a lot of like inconsistency of how people how people group their data is different from system to system. So it's challenging, especially from the product perspective, if you're trying to port your model and make it more generalized. So you almost run into a situation that for the same, let's say I have a model called length of stay, for all the system, you almost have to like retrain it and then understand what are the grouping that they're using and that kind of stuff, right? And then privacy and security is definitely the biggest concern. I think that is also one of the reasons why you're not seeing a lot of freely available data for anybody who is not working for health system to get a hold and even just have a project with. Definitely, we as a company, as a healthcare company, we have to go through a pretty strict security, and there's all kinds of certificates that the company has to get, SOC 1, SOC 2, all around the security and the privacy. As you know, if there's a leak of information, PHI information, that's a pretty big deal for a company. And no matter how big is your company is, and the penalty could be pretty significant. So this is the area. And then a lot of the data we just can't, we can't show. Let's say today, I won't be able to present any sort of customer data. A lot of them, I cannot even mention the name of the customer, right? I cannot tell you what health system that I work with. And that unless there is a publication, a joint publication, and get permission from that perspective. So we can't mention the company, the health system that we work with. Then for any sort of data, it is very difficult for us to have a demo with any other customer who is, let's say, customer A, we build a length of stay model, very successful. Now the customer B wants the same thing, and then customer B asks and say, what can I see your product? All we can say is, I can show you a mock. Either we can somehow find anonymous data, we just have to get, first of all, or we can only show you some sort of dashboard, right? That's the approach that we're taking. I think there was a question that was being asked earlier, right? I don't know if they answer your questions, but definitely we have to do a lot of work around to really present our data. Because we cannot even, let's say, we just simply cannot even say that this result is coming from a customer A. However, what can happen is, let's say customer B reach out to customer A and get consent and say, hey, I'm interested in this model that you partner with Kansai. Can I take a look? Then there is a bunch of NDA that needs to be signed, and there's an agreement. Then that can happen. If not, then there is no way that we can show the result from one customer to another. So we are taking it very, very seriously, even though that's very inconvenient in so many ways. Okay, moving on to when I talk about.
We actually have 3 more questions.
Sure, go ahead.
The first would be, how would we improve patient care or impact on the doctor's decisions while doctors have very specific treatment guidelines that they need to follow for certain disease / countries?
Well, here's the wording. I think this is a message that we're trying to tell a provider and end user over and over again. We are not telling you what to do. We're just providing you additional information, right? So we make it very, very clear. So AI, it is just assisting. In our definition, it's assisting intelligence. It is not about telling you what to do. So all the projects that we have, that we partner with providers, or anyone who is going to interact with patients or members. We use the word members because there are a lot of management group that are managing high-risk members, so-called members. It's a big disclaimer that we have to put out. We're not telling you what to do. We're just basically give you additional information. So later on, I'm going to touch upon, I think the next slide, I'm going to touch upon why is it challenge for us, right? This is exactly trying to address some of the questions of like, how can I convince the provider that the prediction has value, right? So I can jump to the last point over here, and then I can come back to the front, is the interpretable models. So every of our, in order to be successful in healthcare for machine learning or for any data scientist, you need to do more than just say, here's your risk score, here's your prediction score. This patient is 0.8 likelihood of being admitted to hospital, for example. And that's never gonna fly, right? So you have to take one step further. That one step further is you have to provide them with information of why the model thinks so. Not why you think so, but what the model thinks so. So there are, I gave you two examples, which is the line model and the Shapley value model. So they are different in the sense that they are explaining on the individual instances. They are not like, they're not like feature important plots. The feature importance is only telling you what is the model as a whole think, the feature that's important. The line, the Shapley, there's some other explanation model, interpretable models will tell you what does the model think for that one particular prediction. And then we are obligated and we're committed to show them the result. Basically, if you look into, if I say this patient is high risk, and then if some of the risk factor comes up, some feature that we use, for example, polypharmacy. This patient is taking 3 different kinds of drugs. This patient is recently diagnosed. If these turns out to be popping out as a very high feature importance for the interpretable model, for the Shapley value, for example, then the provider can make decision based on that information, right? So we're not telling you what to do. We're just telling you the model thinks this patient has a polypharmacy problem. This patient has recently had a surgery. This patient also has diabetes, for example. That information will allow the provider to pay attention to those areas and find evidence from his or her own system to make that decision. So we're kind of like just pointing them to a direction that we think, that we, basically the model thinks why the prediction say is high risk. So that's very, very important. If you want to be successful in the healthcare model, you gotta have to provide that. If not, it is very difficult for any provider or anyone who wants to take such risk to act on things that they in a black box, right? Now there are other areas that we want to provide as well. So one of the challenges for the prediction model, this is more like a challenge if you're trying to build a product, a repeatable product. So if you are working for a hospital or working for a particular doctor, and then, or you're working for more of a consulting company where all you do is just customize a product that is specific for that customer, then you probably don't have that problem. But if you want to build a product, a model that is portable and applicable from one health system to another, it could be quite challenging just because data is complex and the data source may change from one place to another. Now, the second thing I want to mention is the fairness and the bias metrics. So for all the models that we produce, we have to run through these metrics. We have to report those metrics, right? So it's important for us to know whether our model is going to result in any sort of disparity in treatment to the patient. And it has to be very transparent. So we show all this, we report all these fairness and bias metrics to our customers and say, here's what we think our model is doing based on our best ability, right? So here are the different metrics. If you're interested, just Google them. You should be able to find these sources. And there's some interesting packages that you can run them easily to. So that's the area. Now, the other thing is the monitoring. Monitoring is very important in the sense that like error can happen anywhere. which happens all the time as well. When you have the data comes in, every time you have a new batch, somehow the system failed to update certain table, but doesn't mean that your model will stop scoring. Very often, your model will continue to score, but it's taking in a wrong feature. The feature was generated from a data that didn't get refreshed. But you continue to provide that insights to the end user without them knowing. So it's very important that you have to build a very robust monitoring system that can catch, like we call the health report, we call the feature report. There's along the way, you should have all this check. If it fails in any other area, then you should know what are the fail-safe mode. So for all the model that we have our internal, we call it clinical insight. So these are comprises of medical doctor, just subject expert in a certain area, pharmacists sometimes. And they will provide us information to say, okay, if this prediction was wrong, what is the impact? Let's say the impact could be loss of money. No, not too big of a deal. Loss of money could be, depends how much you lost. But if it results in death or delay of treatment, those are pretty big deal. So we needed to design a system that can have that can catch it. And then once we detect the error, and we need to decide what to do about it. Do we stop showing the prediction, or do we go back to some pre-existing model, like could be a rule-based model that the hospital already using? It could be one of them. So you can even consider having two results and say, let's say the hospital has been using some form of rule-based for prediction risk, and then you can show that result side by side with your prediction, right? You can do that too. If one fails, at least you have another result to fall back to. It's just all kinds of things that you can do on that front. Now, concept drift is just generally a model monitoring to make sure that your populations is not changing over time. It's just more of a machine learning concept. Then all the models should run through some sort of clinical validation. There should be a pilot period, like a testing period before you completely rolled out. And all this pilot, you should know either if you are not capable of designing this statistical pilot experiment, then you need to somehow get somebody, statistician, or sometimes the doctors know how to do that too, and have a very solid plan to say, hey, is our model actually working, or is our model somehow just acting weird? There's all kinds of things you can find out during this pilot period. Sometimes pilot periods from 3 to 6 months. So, and the last thing that I mentioned is the interpretable models. So the challenge is not all the models can be explained, right? So sometimes you are limited to the choices of the algorithm that you can use. Is there a question?
Yes, there's two more.
Okay.
Do you pull data from multiple EHRs?
Mm-hmm. What's the question again?
Oh, sorry. The
Why,
first question
what?
is, do you pull data from multiple EHRs?
From multiple EHR, are you saying like, let's say a system is using Epic and one is using Cerner? When I say EHR, I'm usually referring to one type, right? So for EHR, the warehouse itself, let's say for a health system, it's unlikely that you will see two EHR systems because it's very, very expensive. But however, you will see scenario, which we see a lot, is the transition. For example, a health system could use a Cerner or Allscripts at some point in time. And then they decided that at the future 10 years, they want to invest in Epic. Now, there will be a period where this data is going to convert or transfer, or I wouldn't say convert, most likely the one that in Cerner will stay in Cerner, and then everything else will be get integrated in the EHR in the future. Now, you're gonna run into a problem. This is a problem, maybe this is what you were asking. The problem is, let's say I needed 3 years of training data set. Now, then if the transition happened a year ago, then I would have half of them is maybe Epic system and the other half of them may be Cerner system. That's very problematic. I think we probably run into that issue once, but I don't remember being too big of a deal given the type of model that we're building and the use cases that we're trying to solve. But you do have to look out for those though. So the meaning of one, the structures of an encounter from Cerner is conceptually is very different. I wouldn't say very different, but slightly different from the Epic, right? Like for example, in our product, we have a length of stay product. We actually built two for the exact same model. We built for two systems. We have a length of stay model for Cerner, and we have a length of stay model for Epic for that particular reason, because the way they define an encounter is slightly different. The meaning is slightly different. So yeah, that's my experience.
Perfect. The second question is, Shapley seems so far to be the leading method to explain models. What are the weaknesses of Shapley from your experience?
What are the weaknesses of Shapley from my experience? I wouldn't comment on the weakness from the algorithm itself, but I will comment on the interpretability of it. When I say that is, what do you do when you have, when the model, through the ranking of a SHAP value, you will have feature like age, feature like this person is between, I don't know, what are the good example? Even like has diabetes, like what I'm trying to get to, or male or female, right? These are the areas that you cannot intervene on. So it's very, very difficult to say, well, you're old. What do you do about it? Nothing, right? And then you say you're male, you're female. It's also not helpful. It's nothing you can change about that. So that's the challenge that we're seeing using the ranking that way. I can't Shapley value as a disadvantage and weakness of it. Although I have to say that we compare a couple methods, including Lime as well. I don't have the name of the rest. We do some experiment on multiple of them. I think Shapley come close in winning in the area of how easy it is to apply, plus how easy it is to explain to a non-technical people of what is actually doing, and then scalability. And in some ways, there are many, many models you can use Shapley as methods to explain. Like for example, Lime is actually quite computing intensive. There are some other methods is very specific to, like I can't remember that. I think it's called the IE something. It's very specific to XGBoost. Let's say your model is only XGBoost, then that explanation model works very well. So with that into consideration, so we are still leaning towards using Shapley. I wouldn't say that is the best algorithm in the world, but it's suitable for what we're trying to do. I hope that answered the question.
Thank you. We actually got one more right after that.
Sure.
I'm a practicing ER physician, seeing lots of problems and challenges that can be tackled with data science and ML AI. What do you recommend for someone in my situation to improve upon or to contact? So I assume ER doctor, ER nurse, right? I'm assuming it's more of a clinical, right? Can I get a confirmation on that? So as a physician, as someone who is providing clinical care in the ER department, and you would like to know what are the suggestions that you can do to improve. I think I don't know where you work, but I actually know several of our, for Kansai, for example, we hire, like I said, we have our own clinical insights, we call it clinical informatic people as well. So these people, and we have two nurses, we have one MD doctor,
And we have one retired MD doctor as well. So he is basically contract with us, working on fun project. He's really excited about it. So, so from what I know, some of these nurses, they actually take initiative. Basically, they learn how to look at the data and how to even just simple as finding analytics insights that they can. So what I'm trying to get to is you should find opportunity for you to be involved in the decision making on using technology or using ML, right? So sometimes, from what I can see, this opportunity, you somehow have to start from some way that you can show other people, I can find insights using this data, or I can find insight using Power BI, or you can start with some project that is, I can show you some resources. I think at the last 2 pages, I will have some resources and link that you can get to. But it's kind of hard to say, because what I'm trying to get to is it really depends on the organizations that you work in, whether how open they are to give you the opportunity or give you that channel to tell them your problems, right? Very often the decision maker are not the one that is on the ground. Sometimes you get really frustrated, as in like, you know, we are talking to people who is actually doesn't even know what is happening on the ground. And from a data scientist perspective, I'm like, no, I don't want to talk to you. I want to talk to the person that's actually, you know, on the ground and really treating those patients. But there is this connection sometimes in some organization having that kind of conversation. So I encourage you to see what are the opportunities there and be proactive. Just show what you can do. I do, like I said, I do see a lot of physicians that actually learn how to write R, do Pythons, and do machine learnings themselves, or build a Power BI dashboard, and it's really fun. Yeah.
Thank you.
Okay. All right, so the next thing I want to talk about is we were talking about trust in model, right? So essentially, that's what the discussion that we have earlier. How do we promote that trust? And other than giving them to say, well, this is the prediction score, this is the risk score, here's what the model thinks from the interpretable model. But you have to do more than that. You actually do have to take an initiative to really educate them and what that means. When I say educate them, first thing you have to make them understand is machine learning is not magic, right? That's the last thing that if you go like marketing talk, like, I don't know, sometimes people from the marketing will tell the client is that we are so good, we can predict this, X, Y, and Z. But you know, a provider or a doctor, they're not going to believe that, right? So you need to do a little bit more, as in like transparency. And first, you got to be very transparent about where your model work well and where is the weakness of your model. So for example, when we are reporting our performance metrics, we don't give them a number. We don't say that our RMSD is this number, our position is this number. We actually provide them different cohort error rate, meaning like if you dissect it, this model is work very well for this group of cohort, but if you try to apply it to cancer patient, it all falls apart, right? So it's not like something wrong with our model, but it is the fact that either the data doesn't have enough information for us to account for that, that specific cohort, or the use case doesn't apply for that specific cohort. So there's many reasons why a specific cohort may not have the equal opportunity, equal performance overall. Then we will provide, like, if it's a regression problem, you will always know, like, from the outlier, the tail end, whether it's on the left tail or the right tail, very often they are not performing very well. So we make a point that we show you where it works well, where it doesn't. So that, matter of fact, this is better than just to convince them that I have this one single metric that outperform whatever other models that you're using. Because that makes people like the more you want to admit that where the error and where the problem is. But first of all, they have to understand model is not magic. It's gonna make error in certain, make mistake in certain area. Be very transparent about that and show them everything they need to know, right? And then you can educate them on, very often they are very interested to learn about machine learning. They think it's very fascinating. So spend time talking through it. How do you interpret position? How do you interpret recall? What is the process? What are the thought process and the feature selection? These are the information. The more you can educate them, the better the interaction in the future and the collaborations in the future. And the more they can trust your model. And opportunity. So we talk about challenge. Just the next thing so what's next, right? If all this problem that we have to deal with, then in my opinion, I think right now I'm not seeing there is a very good end-to-end ML platform being built yet. I mean, our company is building one. I can't comment on how well we are, but pretty good. But we're not seeing a lot of those platforms out there, right? So when I say a good platform, I'm thinking more like the platform that actually have all these healthcare components, anything that we care about, right? Health report, model health report, explanation model. There's all these things that is so healthcare specific. So I see there's a lot of opportunity to build a platform, an ML platform in this area. Now, I'm very, very passionate about data sciences, healthcare. I don't think I can ever go to a different industry and solving other kind of problem because I really get the joy and I really see the impact of it. Every time when we go through our result with our customers, and then let's say we're showing them some of the members that we think is high risk, and then they can actually confirm with us and say, oh, I can't believe I didn't see it before. We definitely should call this person. This person needs to go to a different program. So you can really see the impact that a model can do on an individual life, right? That if this person needs a care right now, they should be getting that phone call right now. So I get a lot of satisfaction and a lot of joy from working in this space. And then, and I also felt like because of I'm in the healthcare, I'm a data scientist in healthcare, it really kind of forced me to learn so many things, many things that I have to learn about, whether it's from the perspective of the data, from the processes, from very often I will Google what does drug do, why are people taking this drug? So I just felt like it is such a good opportunity for me to learn so many different things. Excuse me. I felt like I skipped did I skip? Hang on one second. Okay, I felt like I had skipped a slide. Anyway, so I want to kind of towards the end of couple slides and couple things that people in our company are really like the mantras that we are having is we want to build a model that is trustable, understandable, and actionable, right? So in order to do that, then we have to make our methods transparent, fair, and unbiased. And then we'll have to make our models interpretable. And then we have to provide actionable insights. When we talk about actionable insights is before we even build a model, we really need to understand how are they going to use the model, whether our prediction before you have this design, right? So before you start a project, you always start with a design. Sometimes it's not one single model. Sometimes it's multiple models to solve one problem. There's many ways that you can solve a problem, but your goal should be about that actionability. You need to provide the end user something that they can actually act on. Then the last, you have to make sure your model is safe, that you are not, you're not telling them things that the model cannot do. So I also want to quote one of my CTO. I really like this quote. He said, "We don't believe in artificial intelligence. We believe in assistive intelligence. We leave the decision on how to act in the hands of well-trained experts like the physicians." So that we would truly believe in that. Okay, and in order to really make a difference in healthcare and move the needle in healthcare, given we have so many problems in that area, I think the collaboration is really important. I really felt like I cannot do my job well if I don't have my clinical champion, whether it's internal or external, or if I don't have my engineers, right? So we call it the pizza team, or some people call it the dream team. So you must have this component. It's almost like a team sport. So make sure that you are using people around you to build that team that you want, if you really want to build a very solid model or solid product. And then the true impacts are policymakers drive changes within the health system. I mean, eventually that's what we're trying to get to, right? You can help 1 or 2 patients, but that's awesome. But if you want to drive big change, definitely get involved with the policy if you're in the public health area. The rest of them educates administrator with ROI. This is more like pilot. If you have a pilot, if it's related to cost, then you want to make sure that your model is actually doing what it's supposed to do. If it's meant to save cost, then you need to have a way of measure it. If it's to have a better health outcome, then you need to have a different metric. So identify those KPIs is very important, which is another skill that you need to learn. Then the last thing is educate providers to understand the science behind machine learning. I have some resources. I'm only putting 2 project that I personally touched on and has been announced and published. The rest of them I cannot mention them, or I cannot talk about. So let me know if you're interested. Click on it, and then send me an email if you want to understand, or I can go through it a little bit about it later if we have time, if that's of interest. And the next thing is I just put in 2 links that I felt like it is. First of all, healthcare data, it's kind of hard to come by, but I felt like you may have a pretty good chance of going through the sites and then find some of them. Okay.
All
right.
You don't have any more. You can either go in further in what you were just talking about, or we can wrap it up.
Hang on. I feel like I have 1 slide somehow got dropped, which is quite important.
Sure.
Let me check.
Okay.
If there's any more questions, then I'm happy to answer. Do you want to open up to the audience too, or is it going to be a little bit too
open up to the audience? What do you mean?
Yeah, just
like to talk?
Basically people can just talk. Yeah.
Let me see if I can do that.
To. I'm curious.
Okay. We do have another question. Is could you please explain why you think U.S. healthcare costs are twice as high as other wealthy countries?
Oh, okay. This is you want a political answer? There are many problems that we have, right? I think the way that the way we structure our insurance, it's quite I wouldn't say problematic, but well, maybe problematic is the issue. And we're basically allowing the market to drive the healthcare costs. Could be quite dangerous. And I don't know if that's more of a very broad answer. If you look at some other wealthy countries, they may have more of a social setup where the healthcare cost is not tied into their market. I think that is pretty significant different. There are other areas you can say that our doctors are more likely to want to prescribe certain things. I actually experienced it myself. Like, let's say I go to see my doctor. Sometimes I felt like the test is probably not necessary, but they often come back and say, just to be sure, right? And they also know that the insurance is going to pay for it. And that's why there's no hesitation on prescribing or asking or requesting for additional tests. Then that will contribute to a higher cost. And then that will contribute to, like, it may not, I may not absorb the cost because I have insurance, but then the insurance company is going to absorb the cost there too. So overall, it's almost like a trickle effect. And then you started to apply higher costs here, and then the insurance is going to pay more. And the negotiation between the provider and the insurance is another thing. It's like behind the scene that we are not seeing as well.
All right, great. And it looks like we have one more question. It's actually about KenSci. It's, are there any job opportunities for software engineers or machine learning that are entry level at KenSci?
You can send me a CV and I'll just hand it to somebody. Right now, I personally don't think we're hiring, but there's no harm if I just hand over a resume. You never know. I don't think we're hiring at the moment, only because I felt like there's a lot of, you know, it's a COVID time and everybody sort of like stay put, but doesn't mean that we won't hire in the future. So Dave wants to know the truth. I can't hear you. Sorry, I cannot hear you. Can you repeat that?
Can you hear me now?
Yeah, let's try it.
All right. Yeah, just thank you. Oh, wait, looks one more question. I'm wondering what portion of healthcare costs are attributing to advertising or marketing?
Advertising and marketing. I don't know, actually. I don't think that's an area that, at least from the use cases that we looked at, no, I'm not sure. Yeah, I can't answer that. Sorry. Do you think there's a lot of healthcare costs coming from marketing?
I wouldn't know.
I actually don't know.
The person who asked the question said yes, a lot.
A lot? Okay, well, that's the area that I should educate myself. As far as the, I wouldn't say marketing, let's say the outreach that I have encountered based on the customer that we work with, it's mainly around advertising things like, hey, there's an urgent care in this location. So it's more about channeling people to go to urgent care before they go to ED room, right? So these are the campaigns that I have seen. Another area would be things like advertising, as in like, hey, did you know that we have this diabetes management program? And, you know, it's like a brochure, or it's like a phone call, or like a survey. These are the areas that I have seen with the objective of really, truly, like I talked to this care management, they are truly want to improve the outcome. It's not about money, at least for the client, for the project that I work with.
Okay, great. And another one just came in. What are some of the current methods for developing generalizable ML methods from heterogeneous data? And can you discuss this point?
Okay, that is, let's see. Sorry, I'm just thinking how much I can review. Okay, I think you should have multiple models per solution. For example, if you have a length of stay model, if you want to solve a prediction problems of predicting how long is the patient going to stay for inpatient stay during an episode, during an encounter, then you should build multiple model. When I say multiple model means like, what is the minimum set of feature that you can get away with, still have reasonable performance, right? So if you build a model that is depending on availability of a lab, depending on availability of a vital, you know that when you first admit to the hospital, you're not going to get all this, correct? You're not going to get it, right? Then one day gone past, you may get some lab result coming in, then you know what kind of medication this person is taking, what are the, how is the diagnosis. So when you admit to the hospital, you have something called admitting diagnosis. Sometimes that diagnosis got changed to something else, right? So you kind of have to track this information coming in. So you do have to think about, what is the minimum set of features that I can build that I can guarantee if I go to the next health system, for this scenario, for this event, I will have it. We call it a minimum set, right? Now, then that becomes your generalized model. But then again, your generalized model has to provide values. It has to be better than baseline. It has to be better than existing workflow. It has to be better than the whatever rule base that a hospital is using. Because believe me or not, all this problem, it could be a nurse that keep all this information in their head, right? They know that, if I see this, I'm going to know this patient is going to stay for 4 days, right? So they have some sort of tribal knowledge or something that is captured from the rule base. So your minimum set model has to be better than that. Then that becomes your go-to. Then you can deploy like a day 1, 24 hours model, 48 hours model. There's multiple things that you can do. So don't ever feel like you can only have one model to solve this is a true complicated use cases. So you can have multiple models and have one that can be generalized with minimum set. Does that make sense?
Yeah, that was a great answer. We have, looks like another one just came in. Other countries don't have insurance companies in the middle. If you are looking at healthcare costs, it would be very interesting to look at the amount of advertising costs and administrative costs versus developed countries. Also, it would be interesting to examine the backgrounds of people going into medicine in this country versus other countries. Which country would you say would do it? Would pay more in that example?
I don't know. I mean, U.S. doctor got paid a lot more, right? That's like for sure. Yeah, there's actually one thing I want to brought up is I can't remember the name of it. It is a site that you can actually see what are the association of a doctor to whether a drugs company. There is a publicly available site that you can go to, but it slipped my mind. And it is it's by law they have to report it. For example, if there is a doctor who favor prescribing some sort of branded medication. So if you think about, there are options like generic, branded. There are different, if you look at the insurance, there are different tiers. And if you suspect a doctor prefer a certain brand for higher cost, not based on outcome, you can actually track to see if this doctor is associated with that pharmacy company. They have to report even things like if they receive a meal from them, how many of them, how much they got paid for going to a conference representing the company to give a talk. They have to disclose things like what are the stock how much stock they own of that pharmacy company. So these are all publicly available information you can tap into. Actually, we try to integrate that into one of our products as well. Basically, we identify certain providers for anomaly behavior, and then we wanted to know whether this is associated or there's a way that we can see they're related to that particular pharmacy company. Oh God, it really slipped my mind. But reach out if you really want to know what that is. I can find out for you.
Awesome, thanks. Another question. Are the current explainability models in machine learning enough to satisfy the transparency requirements from your customers?
Yes and no. The model the interpretability of the model, for sure, I think is solving a major problem. It's the trust issue, right? So you give them a black box, they can't trust it. But if you tell them what the model is thinking, they're likely to trust it, but regardless of whether those features are actionable or not. One thing that we do a lot, which is really important, is understanding what are the KPI and what are other information that is required for the provider or for the end user to make decisions. Very often these are descriptive data. So if you look at the dashboard we're trying to build, I think half of it are all descriptive data that we are carefully curated, and we run a lot of UAT, we get feedback, we get into their head and say, in order for you to make a phone call or decide treat or not treat, what else do you need to know? Sometimes we'll build, we call the supplement feature, even though those features may not be part of the model, but we provide those, like, especially like, for example, lab, right? What is the average lab result for a very particular lab that is associated for diabetes, for example? They want to know. So these are very carefully curated descriptive data that we are showing to our end user to help them to make that decision. So yeah, so it's both, right? Whatever information that you can provide them in one single page. And then also keep in mind, end users sometimes don't have a lot of time log into different systems and go and find out, give me the average of this patient's lab result for the last 12 months, for example. You never see a doctor be able to do that when doing a visit. However, if you know that metrics is important for a decision making, you pre-compute that for them along with your prediction model. You show it them side by side. That will really help them to make a better decision.
Awesome. Thank you for that answer. And thank you for withstanding all these questions. They've been just coming in after question after question. But it looks like that should be it for you. So you're off the hook. Thank you everyone for attending the talk, and thank you, Jasmine, for your time. We hold these talks to inspire the people to further learning, and all of you have done that if you've come here today. If you haven't already, please make sure to subscribe to our YouTube channel, and also please make sure to come to our next meetup, which is going to be on September 30th. How do models learn? Thanks, everyone, and have a good night.